of the chair. We move on to the extended dual antiplatelet therapy after ACS PCI, current evidence and future perspectives. Dr. AjayPandey, Director and Chief Interventional Cardiologist and Head Department of Cardiology at Galaxy Hospitals, Varanasi. Dr. Pandey has 12 minutes plus 3 minutes for discussion.
Good afternoon, respected chairpersons and my panelists. I'm really very enlightened to be here among my teachers and my friends at my alma mater, where I have finished my DM program. So the topic allotted to me gave me one more very important clinical problem, which is more or less expansion of the part which Dr. Agrawal was discussing. That I've got one patient who's a 60-year-old male diabetes with hypertension, smoking, CKD, post-ACS underwent multivessel PCI some 32 months before. Presently is asymptomatic but uncontrolled hypertension. His present medications are aspirin, clopidogrel as a dual antiplatelet, atorvastatin of a higher dose, ramipril, beta blocker and OHA. The question posed to me is, does the patient require DAPT? I think the answer is coming in future slides. Is the prescription evidence based? We have to see whether we need to give this dual antiplatelet or we have to replace with the better ones. Is he having a high ischemic risk requiring DAPT? Definitely yes, because is there a need for long-term ischemic protection post-MI? As Dr. Agrawal has discussed that we have got a lot of ischemic risk last, and the REACH registry which was discussed recently, the patient who have ischemic events at twice the risk of MACE for up to 48 months after the ACS. And in similar in the IMPROVE IT trial also, that CAD patient with multivessel disease and or diabetes are at sustained or higher risk for up to 7 years post intervention. And the complex PCI patients also, they have a prolonged risk of secondary events. So patient who had a complex PCI, like in my patient, had a significant high risk of MACE, MI and secondary events. So what is the evidence for long-term DAPT post-MI? There are two, the guidelines recommendation and the patient profile for extended DAPT. What are the guidelines suggest? Is a recent review which has been published in JACC regarding the extended duration of dual antiplatelet therapy after percutaneous coronary interventions. And how long is too long? There are 4 important trials which were discussed here. Out of that, DAPT and Pegasus have got those who have included, the Pegasus has included ticagrelor both 60 as well as 90 milligram, whereas the DAPT 2014, which was finished, included clopidogrel of 65% patients and prasugrel of 35%. The rest 2 of them, the desolate and the optidual, they were having of duration of 12 versus 36 or 33 months of duration of therapy, and the drug was only clopidogrel. And these patients, they have got no difference in the primary efficacy endpoints results in these 2 trials, whereas the Pegasus has shown decrease with extended DAPT of 7.85% versus 9% primary driven by MI and stroke, and similar with the DAPT, but the type of stents were different. In a DAPT trial, they have got a first generation as well as second generation. The only Pegasus has got the difference that it has compared both the low-dose ticagrelor as well as the high-dose ticagrelor. There was no stenting in 20% of patients and BMS in 41% and deaths in 39%. So if you look into these, the guidelines, what they suggest, this is a comprehensive slide that, recommendation for DAPT therapy in patients with ACS. They have got medically managed patients as well as patients those who got a PCI with deaths or BMS. The medically managed patients, those who have been divided into high bleeding risk or low bleeding risk. Definitely the high bleeding risk patients, they have to have a lower DAPT therapy of 1 to 3 months, or ACC-HA recommends up to 6 months, but no high bleeding risk can continue for 12 months. And those are the group of patients, those who can have a extended DAPT therapy for 12 to 36 months. And in these group, the ESC recommends for ticagrelor preferred over clopidogrel, but the ACC-HA says that more than 12 months clopidogrel, prasugrel, ticagrelor, they all can be used. But definitely there's a lot of hopes which are there. And same is with the PCI with deaths. Those who have got a high bleeding risk, they have got to have a lesser duration of 6 months or so. But to those who have got a no high bleeding risk for 12 months at least, an extended therapy of 12 to 13, more than 12 months can be recommended. So this is the, in a nutshell, of current guidelines on DAPT usage. As we all know that ACS patients with medical therapy, BMS or DAS, at least 12 months, and with European Society guidelines, and for ACCHA at least 12 months by 2016. But more than 12 months may be considered in patient with prior MI and low bleeding risk with high risk of ischemic events, and we will discuss what are those high risk of ischemic events. And the similar recommendations are with ACCHA as well. For stable CAD and BMS and stable CAD with DES, usually the lower doses, the lower duration are recommended. But if you compare both ESC guidelines and ACC guidelines, in all PCI patients with stable CAD, though there are different varieties of stable CAD as Dr. Agrawal has already discussed, DAPT prolongation beyond 6 months and up to 30 months may be considered in patients who have tolerated DAPT and are at low bleeding risk but high thrombotic risk. That's a very, very important aspect. But patient undergoing pre-PCI for ACS, DAPT prolongation beyond 12 months may be considered in patients who have tolerated DAPT without a bleeding complication and who are not at high bleeding risk. So this is the slide which shows the dual antiplatelet, how long is long enough. For patient at a higher bleeding risk with a low ischemic risk, short duration of DAPT 6 months is acceptable, but we have to decide by precise DAPT score. This is a very important score which is taken for percutaneous coronary intervention at the time of intervention, and if the precise DAPT score is more than 25 and not high risk for ischemia, the short dual antiplatelet can be taken up, but less than 25 planned for 6 months to 12 months or so. But for patient continued ischemic risk factors and low bleeding risk, extended DAPT up to 30 months is recommended, and that's what it is said here, that we have to use here a DAPT score, and we have to seek for major bleeding risk events. Those who have got no bleeding or ischemic events, they can be taken up for, the risk has to be calculated, and with the risk less than 2, discontinuation of the dual antiplatelet, but more than 2 we can continue with dual antiplatelet. The patient risk profile depends upon patient-related factors, comorbidities, and intervention-related factors as well. And we all know that bleeding risk and ischemic risk has to be balanced, and we have to calculate and see into all these important bleeding risk factors like high precise DAPT score, creatinine clearance, WBC count, age, frailty, hemoglobin less than 10, and ischemic risk by complex PCI, ACS, multivessel disease, more than 60 millimeter of stenting, CTO, and left main, and more than 3 lesions, bifurcation, and so on. This is regarding the risk scores validated for dual antiplatelet therapy during decision making. The precise DAPT score is important at the time of coronary stenting, and these are few important factors. As I have already discussed, that score more than 25 short DAPT, less than 25 we can go for longer DAPT, and for after 12 months of uneventful DAPT therapy, the standard DAPT of 12 months versus long-term DAPT for up to 30 months can be taken up with all these DAPT score, and if the score is more than 2, the longer DAPT can be suggested. And these are the important characteristics which are giving a benefit of extended duration of DAPT. That's ACS presentation, prior ACS, like many of our patients, and my patient itself had already a prior MI, peripheral artery disease, diabetes, renal dysfunction, tobacco or cigarette use, left ventricular dysfunction, congestive heart failure, stent diameter less than 3 millimeter, vein graft, and high CAD burden. The factor associated with increased bleeding risk, as I've already discussed, age more than 75, frailty, anemia, hemoglobin less than 10, CKD, hospitalization for bleeding, prior stroke, and regular need for NSAID and prednisolone, they have to be taken care of. And interventional factors are also very, very important, because when we are using multiple stents, the amount of risk is high. Bioabsorbable scaffold and left vein stenting, they all need to be having a higher risk. The patient-related factors we have discussed. So the important aspect is to balance the ischemic event versus bleeding event, and safety in extended duration of DAPT is very important. Non-adherence is a major cause in our country as well. As you can see that in Asian populations, the non-adherence to CV medications, not only antiplatelet, antihypertensive and statins, we have already seen in our clinical practice that the people are unable to take it on an adherent basis. I just want to have a few slides of discussion on Pegasus TIMI 54 study because it's one of the most important study regarding the DAPT long duration. And the patients here were around age more than 65 with diabetes, second prior MI, multivessel disease and chronic non-end-stage renal disease. The important part was that the high dose versus low dose ticagrelor was also used and compared with aspirin combination and versus placebo, and a minimum of 12 months follow-up and even 4 months in 1 year then semi-annually was done in these patients. And ticagrelor plus aspirin showed a 16% relative risk major adverse cardiovascular events versus aspirin alone at 48 months of the index MI. And we all have realized that benefit established across primary and secondary endpoints in this very important trial. The major bleeding was higher than placebo, but the fatal bleed or ICH was similar between ticagrelor 60 milligram and placebo, and that's one of the most important finding which has come up, that lower doses of ticagrelor was equally compared to placebo, and switching from 90 milligram to 60 milligram at 1 year juncture can be most beneficial in the group of patients where we are taking them for a longer DAPT score. So Pegasus TIMI 54 analysis of net clinical benefits was irreversible harm was seen, and to conclude the Pegasus, the patient who had an MI or a previous ACS at a heightened risk of ischemic events, and this is the first prospective randomized controlled clinical trial, and the prolonged antiplatelet therapy with ticagrelor plus low-dose aspirin may present a new strategy for reduced antithrombotic events apparently selected patients. Why we are using ticagrelor as an important drug? Because we can compare other two antiplatelet like clopidogrel and prasugrel. We have all understood about the pharmacology of these two drugs. We know about the clopidogrel resistance a lot. An Indian study published in Indian Heart Journal by Guha et al. That says that 1 in every 3 patients have either completely resistant to clopidogrel or poor responder. So that's a really important aspect for many of our patients. And even higher doses of clopidogrel cannot compensate for that. And the Gravitas trials has shown that high dose clopidogrel of 150 milligram per day does not help improve outcomes of CV death. And similarly, the Plateau trial was taken, though it was not a DAPT longer duration trial, but it has shown that that's why the ticagrelor was better compared to clopidogrel. Though ticagrelor was compared with prasugrel, but there are a lot of limitation with prasugrel, and prasugrel can only be started after indication for PCI has been established and based on absence of contraindication. So to summarize my points, the important point for our DAPT patients are that the risks stratify patients as per high and low bleeding risk after your ACI, ACS or PCI, and patient defined as a high bleeding risk in the analysis appear to be derived no benefit in reduction of the primary endpoint with DAPT. Conversely, the high bleeding risk with at least 2 ischemic risk factors appear to derive statistically significant relative and absolute reduction in primary outcome with low doses of ticagrelor. And patient with, we have to see that high ischemic risk factors and low bleeding risk are the important group of patients, those who can be tackled up. MI, diabetes and multivessel disease with more than 3 stents are strong ischemic risk factors. Non-adherence and early discontinuation is very important. So coming to the question which I posed for the clinical problem, that does the patient who has already for 32 months require DAPT? Definitely, yeah, he required, because he had multiple ischemic, high-risk ischemic risk factors of diabetes, smoking, CKD and all. The prescription of DAPT in my patient was not up to the guideline directed, because I would like to prefer a low-dose ticagrelor over clopidogrel, and definitely he is a high ischemic risk requiring DAPT with not that a great risk of bleeding risk. So, but we have got other justified options other than DAPT in this group of patients, as Dr. Agrawal has already discussed. As COMPASS has shown that aspirin with low dose rivaroxaban may also be one of the important aspects. And best is for all to risk stratify and individualize the patient for DAPT therapy in long term. Thank you all.
Okay, we just have time for one question for Dr. Pandey.
Can I have the views of my panelist? Dr. Kheda is here. What is your view on the dual pathway inhibition which was so passionately talked about by Dr. Agrawal? And in reference to Dr. Pandey's case, would it be dual antiplatelet therapy or it will be dual pathway inhibition therapy for his patient on a chronic long-term basis? What would your choice at the present moment be?
As far as the dual pathway inhibition is concerned, the COMPASS trial was very convincing, and I strongly feel that, as Dr. Agarwala has said, that we should take the COMPASS to the clinic. We are missing on using this low-dose rivaroxaban in many of our polyvascular patients because we don't realize that the benefit of low-dose rivaroxaban and this dual pathway inhibition will give us so much benefits. As regards to Dr. Pandey's patient, I feel that his patient should be now on dual pathway inhibition rather than a dual antiplatelet therapy because it's over 34 months. Although he is a high-risk patient, he has multiple risk factors. But still, he is now probably a candidate for low-dose rivaroxaban.
And you don't think that despite the so many risks which he enumerated in his case, DAPT would be a better choice than DPI? Because DPI will be used only in patients who are very stable and you don't have that kind of high risk and you have a multi-vessel, multi-system atherosclerosis.
Yep, we've just run short of time, Mr. Chairman.
Yeah, okay.
We'll have to move on.
Can
to
I
the
just one comment from the audience, senior persons, what would your choice be? Dr. Goha is here. Are you, okay. Dr. Ramesh Thakur, what would your choice be? Long-term dual antiplatelet therapy in this case, or would it be dual pathway inhibition with rivaroxaban vascular dose?
I would agree with Dr. Pandey that in case of a very high risk, if with multiple stents or post-CABG, or the person has got a compromised early function, advanced age, element of CKD, element of COPD and all, then one should go for dual pathway rather than DAPT. That is how I believe. Longer the stents, more is the number of stents, less is the function, more is the age. I believe lifelong dual pathway scores somewhat over the DAPT.
Okay.
Thank you, Dr. Pandey.
Thank you.
One thing, Dr.
One
Pandey,
last
I wanted
comment
to ask is, as a physician, see what we see in our day-to-day practice is once the patient suffers from ACS or post-PCI, they usually go back to the village and they keep continuing with the same medication, that dual antiplatelet. They come back to you after 4 or 5 years. I don't think the risk of that is so much talked about. Risk of bleeding is there with so much if you continue for 4 or 5 years. And patients are absolutely okay on those dual antiplatelet drugs. And as far as the resistance you say is there with clopidogrel, but had it been like that, then patients don't come back with the symptoms.
Okay, so the question is still wide open. I mean, the choice is between, dual pathway inhibition
safe
But the
and how much
evidence doesn't show
dual
the
pathway
Totally
inhibition,
run out
he
of
said,
time
is safe,
for this
as
session.
was pointed out.
If we could move ahead with the next
Yeah.
presentation. Thank you very much, Dr. Pandey. Yeah.
Actually, Dr. Pandey was referring to one of my papers in the Indian
Yeah, that
Heart
is why I
Journal
asked you that question.
regarding the clopidogrel resistance. We got nearly 1 in 3 and 33% or so. We are doing another study with clopidogrel with a genetic polymorphism. Here also we found that there is around 35% around clopidogrel resistance, but they do not translate into a clinical outcome. I don't know why. These are all patients who have been stented, and many of them went home before we could modify their drug. But hardly anybody had a stent thrombosis.
Yes, that's true actually.
So
The
I
papers
just
earlier
cannot
also have
say
said
whether this in vitro resistance
actually
can
translates
translate
into clinical
an
effects.
in vivo any thrombosis or something.
Okay.
Thank you.
Thank you,
Mr. Chairman,
Dr.
Thank you very
Goha.
much,
Thank you,
Dr.
speakers.
Pandey.
Thank you,
We'll
panelists.
move ahead to the last presentation.